clear-cut whoop in this voice. I will send the video on the group, inshallah. So that was a case of most likely pertussis.
Yes.
Okay. So what can be happen to this child? What are the complication in this case? What can be?
With pertussis, a subconjunctival hemorrhages will be there,
Hmm.
and it can lead to pneumonia.
Hmm.
Respiratory failure can be there with this, and others.
Think of other things also. Try.
Hmm. Like very much pressure she is giving, so maybe intra-abdominal pressure can cause hernias.
Hmm. Anyone else like to add anything?
Yes, doctor. Over here, I think the most important one could be the apnea, which doctor was already appreciating,
Hmm.
and then it could also be a subacute emphysemas can also be there.
Hmm.
So these were the
Seizures.
two that I think. Yeah.
Seizures
So
also.
if there's apnea, then seizures will be there for apnea. Then
Hmm.
they can be gagging, they can be bradycardia. So
So
all these
these
things can
things
also happen.
keep in mind, right? From head to toe. Okay, what doctor mentioned and adding on these
Hmm.
things also. Okay, okay. How will you manage this case, Dr. Priyanka?
So for pertussis, I think we have to uh, keep the patient calm in a resting position, that is not it's likely we have to do not there is a
Your voice is very
distress, then can
going.
offer oxygen according to
Doctor,
the severity.
sorry, can you please repeat because your voice was coming and going. It's not, it's breaking a lot. Try one more time. Start from again the management plan.
So as it is a ma'am, now it's clear.
Yes, it's a little bit better. I don't know what happened. Suddenly, your voice is everybody else also facing the same, or am I the only one who's not able to hear her clearly?
No, no, the voice was breaking in the middle, but now it's clear.
Okay, carry on, doctor.
So as I mentioned, the we will involve the multidisciplinary team, and my consultant pediatrician will be involved. And pertussis, as it is a notifiable, na? So we will notify the disease and keep the patient isolated,
Hmm.
and we will notify and tell to the infectious team also. So as a separate will be a room will be there for the patient, and then we have to manage the patient accordingly. If the patient is having like a respiratory distress, and if resistance is less than 92%, then we have to provide them the oxygen, supplemental oxygen to the patient. And
Hmm.
if he is not taking orally, then we have to provide the feed through a nasogastric tube. First of all, with the oral small frequent feed, if he is not able to tolerate, then we can give him likely with the nasogastric tube also. And if is not tolerating on the nasogastric tube, then IV fluids will be started accordingly with a fluid restriction to 80%.
Hmm.
And apart from this, we can start with the IV antibiotics. I didn't remember the choice of antibiotic here. Yes, I think the clarithromycin and the macrolide group is the choice of antibiotic in this. So clarithromycin and azithromycin can be given according to the age, and the dosage will be provided according to the age and the weight of the patient. And we have to monitor the patient carefully for any kind of complications. And also, uh, like ma'am, in this the contact history is positive or not. So we have to isolate the contacts
Hmm.
also in
Hmm.
the patient.
You will take the history from the parents. Okay. What else?
Depends, huh? And we have to monitor the patient by likely we have to monitor the urine output and the IV fluid intake output of this patient, and monitor for any other complications in this patient, monitor for the oxygen saturation, if there is any epic episodes or for seizures.
Okay, okay. Anything else anyone would like to add?
Nothing, doctor. I think she covered everything. Maybe we could just talk about the immunization is very important. So prevention is more important than cure in this. And I think she covered everything else. Priyanka Mashallah, she covered everything. She talked about
Mm.
clarithromycin, azithromycin,
Hmm.
and I don't think anything else is left. Nothing. She covered everything.
Okay, okay, good, good. So that is what, because this is these kinds of the video you're being shown, and you have to mention the same like intensity of the situation, the vital signs, and the management plan also, like stepping up, discussing the complication till the examiner stop you and throws the next question to you. Okay, okay.
Maybe we could talk about what bacteria causes it. Then the cause will be Bortella pertussis
Hmm.
bacteria,
Hmm.
and this cough
Mm.
persists more than persisting for two
So the
or more
folder which
weeks.
I shared with you, there are some additional like literature from in that folder also, which I share on group. So you can
Mm-hmm.
go through that. Pertussis is there in that also folder. Okay. So
Okay.
go through all the cases that are being there. Okay.
Mm-hmm.
Madhya, you would
Okay.
like to add anything, or should we get the next one?
Yeah,
I think
I
probably
want to ask what specific thing can you find on the
Sorry, ma'am.
Sorry, I think our voice is breaking.
Madhya, we cannot hear you actually. Maybe you can write the question on the group because your voice has gone. Just a second,
can you
maybe
hear now?
switch.
Can,
Yeah, we can hear you now.
yeah, I'm asking on CBC, what is the specific finding that you see in patients with pertussis?
Ma'am, on CBC, there will be the increased total lymphocyte count that will be greater than, I think, 20 to 30,000. It will be greater than this. And most likely, the lymphocytosis will be there.
Yes, lymphocytosis is very important. Sometimes it can be very high and you can have atypical cells also, okay?
Yes, yes, atypical cells also. I mentioned the count will be greater than like 18 to 20,000. In the 30s, we can also found the total
Like even
lymphocyte
more
count.
than 50,000 also sometimes you can get. So it's just like
Yes.
leukemoid reaction can happen, okay?
So what you will
Leukemia
keep in
reaction.
the differential for this case, differential diagnosis.
So as the
ALL.
atypical cells are there, so we can keep ALL also, acute lymphocytic leukemia.
Good, excellent.
Okay, okay. So, okay, that's good. And let me know if you guys are hearing the sounds or not. I don't know. Next time I will just run trials with Madhya before putting up the videos because the first one goes, so I thought the rest of that will be there also. Let
Doctor, I
me-
think something's maybe you've switched off that there's a option in the share system sound. Just I think maybe you just have to switch that on.
Let me see. Just let me know about it. Because the mother sound was there. It was there in the last video. Even it was less.
Mm.
Can you hear the sound now?
No.
No.
No sound till now? Just a second.
Now it's there,
Huh.
but it's gone again.
So, yes, can you tell me what was that?
Doctor, I couldn't hear the sound,
I will
but
put it again. At some point, did you hear that sound? At some point, did you hear?
just very like harsh breathing. Like That's the sound I heard, just like in the middle, just once.
So it means it is this sound with this picture. Just keep in mind the picture of the child, especially this child.
Mm.
Okay. You can comment on this child. Okay. Let me see.
Okay.
Tell me the previous picture. What was that?
Doctor, I see an infant lying comfortably in a home setting. He has some added sounds to his breathing, but his breathing pattern does not seem to be in. He does not seem to be in acute respiratory distress. He has no devices attached to him, and he seems well grown for his age. I could appreciate the child has abdominal breathing, and he has what it sounds like inspiratory stridor right now with hoarseness of the voice.
Okay. Did you appreciate something or else also in the general look you will mention?
No dysmorphic features.
He is a happy, playful child. He is not like
Yeah,
looking sick.
yeah. I said no distress. No, no distress.
No distress, and then the general appearance also does matter, right? Because he doesn't look sick.
Okay.
Yeah, either he's a sick-looking child that you can mention for hospitalized kids, and if he's at home, because the diagnosis will lead to towards you that cause. He's not coughing,
Mm.
so okay. But when he's having some noisy breathing, so it can be what can be the differentials in this age?
Uh, Doctor, in this age, it could be choanal atresia. It could be simple nasal blockage due to an upper respiratory tract infection. It could also be, again, foreign body inhalation of some sort. And then it could be, because I was hearing stridor, then it could be croup. And then, like we talked about all the other things in like the newborn setting. So maybe any of those anatomical malformations.
What about the top of the list if some playful child comes at this age? So what is the most likely differential?
Mm,
Acute,
playful
like.
child.
Hmm?
Foreign body inhalation.
No, foreign body inhalation, there will be something else, no? Some sign, something else will be there.
RSV, but
Huh?
RSV, yeah, RSV,
So RSV causes
respiratory
what?
syncytial virus,
No,
Bronchiolitis.
RSV are also
Bronchiolitis. Mm.
they're not very happy.
Bronchiolitis can be there, or like
Mm.
viral induced disease can be
Yeah.
there. Early induced asthma
This
can
is
be
a
weakened.
happy
Can
child,
be
na happy child. So usually,
uh,
is it like if they're showing a coughing foreign body, they're difficult, they have a choking episode. They will not show like
Mhm.
the child only. You can keep it in differential lower down, but they must be in the video, they will clue with a choking episode. So there seems like a happy viral wheeze or kind of a bronchiolitis in which he is happily playing and just noisy breathing while he's been moving around.
Okay, doctor.
That will.
Shumila, there's Strider also, no? Or no? I felt there was Strider also.
No, actually, there was no stridor. There was a kind of a wheezing in between, the wheezing in which was there, not stridor.
I'm thinking there's Strider.
No.
Okay.
Because if there is no croupy sound also was there. It was wheeze, but maybe the video quality was this much. You were not able to appreciate it clearly. But I'm telling you, in the exam also, they are putting these kinds of videos. Just keep your
Mhm.
other things in mind, like the child is in a happy setting and this and that, and make your three top
Mhm.
differentials on the basis of the overall picture. Okay, not just on the basis of the breathing sounds, overall picture. And then the examiner will give you a clue when if you put your first three differential very good, like if it's likely this, what you will do to tell me the management plan. But your first three differentials should be finding, most specifically the first diagnosis is important. But if some quality of video is poor, even he's gonna help you a little bit. So you make the relevant three differentials, keeping in mind the whole picture. Like the child is at home, no additional things are there. He's happy, playful, playing. Okay, so bronchiolitis and viral wheeze is very common in such kids. So how will you manage this case if it's viral wheeze or bronchiolitis?
And Dr. If it's viral venous or bronchiolitis, I will like to measure, I would like to first take the child's vitals. And according to what the vitals of the child are, I will go further with my treatment, managing the ABC accordingly. If the child is dropping saturation below 94 and 92%, then I will definitely need to take the child on some appropriate oxygenation. We will start with again the step up thing with oxygenation. We'll start with nasal prong and then we can further step up according to the child's condition. I will provide the child with proper nutrition and hydration at this point. Since the child will be in respiratory distress, so maybe NG feeding or maybe just IV fluid and nutrition may be needed at this point. And if it's bronchiolitis, there is no role of any sort of nebulizations or IV antibiotics in this.
So you mentioned about
So
it.
it's mostly a
No role of
symptomatic treatment.
IV antibiotic, bronchodilators, or steroids, okay? Or maybe the examiner will ask you, then your question is no. No role of IV antibiotics or steroids.
But this role of
Yes,
hypertonic saline can be
yes,
used.
doctor. Hypertonic saline, yes, but no
Hypo-
other like budesonide and none of those. There's no like medication, not really.
Mm.
Okay, good.
Maybe I can just say humidified air and
Certified.
hypertonic saline.
Mm. Okay. So are you guys familiar with some of the spacer devices and the inhalers? I remember
Yes, doctor.
we did the respiratory system. So do go through that because it's important and for the video stations today, what we discussed today and what is there in that protocol. So do go through those all those things, okay?
So
That I'm-
protocol wise, doctor, we only have two actually. So we have the normal inhaler, which we give for 15 and above. Then we have this spacer device, which looks like a long tube. One end you add the inhaler, and one end is for the mouthpiece, and that is given between 5 to 15. And below 5, we add a mask to the spacer device. So it's a mask, spacer, and then the inhaler.
Having an asthma attack. Sit your child down, keeping them upright in a comfortable position. Remain calm. Administer their reliever medication. E uses a spacer with a face mask and a metered dose inhaler. Shake the inhaler 4 or 5 times. Place it in the back of the spacer device and apply the mask to the child's face. Keep your chin elevated and press the inhaler. This releases 1 dose. E takes 2 to 5 slow, steady breaths to inhale the dose. The valve in the mask will move back and forth. Once she's taken those breaths, remove the spacer from her face and wait 30 seconds. Continue to comfort and reassure your child. After the 30 seconds, shake the inhaler again 4 or 5 times and reapply to your child's face. Give a second dose. Encourage Eve to take 2 to 5 slow, steady breaths.
Okay, guys, so that was the important thing, which because the way how the inhaler being used, okay, just be familiar with that. The way we showed you the EpiPen, okay, few of the things, few of the inhalers. Then when we will do mock of the respiratory system, we will discuss about the like we will ask you about the step up and step down approach. There is one more thing I would like to tell. We had made a schedule for the next like till 15th, like till your exam date. So we will share it with